now we are going to discuss another pigment deposition, which is calcium, right? So calcium deposition, which is called as calcification. So now we are going to deal with the calcification, right? First, we should know that what is the ideal environment for calcification whenever there is a alkaline pH. So after the tissue damage, when pH is alkaline, that will promote calcium deposition, right? So calcium deposition is seen whenever there is an increase in alkaline pH of the tissue, right? Second important thing, where you will see the calcium deposition earliest. So it starts in calcification, it starts in mitochondria, right? So calcification starts in mitochondria, and very important MCQ in exam. Calcification starts in mitochondria in entire human body except for one place. So that exception is very important, except for kidney, right? Except for kidney. In kidney, calcification starts in basement membrane. So in kidney, it will start in basement membrane. So that point we have to keep in mind, right? So calcification starts in mitochondria, except for the kidney. In kidney, it will start in basement membrane, right? According to the status of tissue, we can divide calcification into two major types, right? So we can say that pathological calcification are of two types. So here I am saying calcification are of two types, right? One is called dystrophic calcification, and second is known as metastatic calcification. So dystrophic and metastatic calcification. What is the difference between dystrophic and metastatic calcification, which examiner asks in exam also? When you find tissue is damaged, see this tissue is damaged. So tissue damage and calcium level will be normal. So tissue is damaged, calcium is normal. Which kind of calcification you will notice? That is how question is asked in exam. What I am saying, tissue is damaged, calcium level is normal. So which type of calcification? Dystrophic. D for damage, D for dystrophy. That is how we can remember, right? So this is the mnemonic. You can understand this is a kind of mnemonic. Dystrophic is seen in damaged tissue. Damage, D for damage. Remember, D for damage, D for dead, D for degenerated, right? So everywhere we are seeing D, right? So damaged, degenerated, dead, you will see dystrophic calcification. So tissue is damaged, calcium level is normal, dystrophic calcification. What about metastatic calcification? In metastatic calcification, tissue will be normal. Here you will find normal tissue, but the calcium level will be high. Calcium level will be abnormal, or you can say calcium level will be high. So this will be the metastatic calcification. So we have to understand the basic difference between dystrophic calcification and metastatic calcification. Tissue damaged, normal calcium; dystrophic, tissue normal, calcium high, it will be metastatic, right? So what are the examples of the dystrophic calcification? So whenever you find any inflammation, say TB inflammation is causing damage of the lymph node tissue. So TB lymph node is an example of dystrophic calcification, because TB bacilli is damaging the lymph node. After the damage, D for dystrophy, calcium will be deposited. Similarly, when you are seeing rheumatic heart disease, what will happen? Valvular damage. When there is a valvular damage, valve is having damage, and after that calcium will be having deposition. So valvular damage in rheumatic heart disease is another example of the dystrophic calcification, right? Another example of the dystrophic calcification. There is another important example that is called Monckeberg medial calcific sclerosis. So Monckeberg medial calcific sclerosis was All India 2014 MCQ, right? So we have to keep that in mind. There is a tunica media. In tunica media, there will be calcium deposition. Because of that, there is a hardening. That is why it is called as Monckeberg medial calcific sclerosis. Tunica media is damaged, so tissue is damaged. Then calcium gets deposits and causing hardening of the vessel wall. So this is called Monckeberg medial calcific sclerosis. And the fourth and important one is the Psammoma bodies. Psammoma bodies. So Psammoma bodies, we know in cancers it is seen. So tumor cells are abnormal, right? So tumor cells are abnormal. So Psammoma bodies are seen in cancers like we know meningioma. So it is seen in meningioma. So meningioma, mesothelioma, or papillary RCC, or you can say in papillary renal cell carcinoma, or you can say papillary thyroid cancer. So all these things you will find Psammoma bodies, and all these areas you will find abnormal tissue. So tissue is abnormal, normal calcium level, these are the dystrophic calcification, right? Metastatic calcification, as we have discussed earlier. In metastatic calcification, tissue will be normal, calcium level will be elevated. So the question comes to our mind, what is the most common cause of the metastatic calcification? What is the most common cause of metastatic calcification? This was the DNB question previous year, right? What is the most common cause of metastatic calcification? So most common cause of metastatic calcification is hyperparathyroidism. Hyperparathyroidism. So hyperparathyroidism is the most common cause. Which type of hyperparathyroidism? Type primary or secondary? So your answer should be primary hyperparathyroidism, right? So primary hyperparathyroidism is the most common cause of metastatic calcification. What is the most common cause of primary hyperparathyroidism? What is the most common cause of primary hyperparathyroidism? Your answer should be parathyroid adenoma. Parathyroid adenoma. So parathyroid adenoma is the most common cause of metastatic calcification, and that was the question in DNB and All India exam, right? So parathyroid adenoma. So this was the question. Parathyroid adenoma is the most common cause of metastatic calcification. So this was the question. This was the question in DNB exam, right? Most common cause of metastatic calcification is the primary hyperparathyroidism, hyperparathyroidism, and primary hyperparathyroidism most common cause will be parathyroid adenoma. So this is how we have to understand that parathyroid adenoma is the overall most common cause of the metastatic calcification, and they are the cause of the primary hyperparathyroidism also. So this is the one cause for the metastatic calcification, right? This is the one important cause for the metastatic calcification. What are the other causes of the metastatic calcification? Metastatic calcification can occur in renal failure also, right? So in renal failure, it will be associated with secondary hyperparathyroidism, right? So this will be secondary hyperparathyroidism, right? So this is the secondary hyperparathyroidism, renal failure, or it may be because of the excessive vitamin synthesis. So now the question comes to our mind, which vitamin excess will cause metastatic calcification? Suppose this is the All India question, and examiner asks you which vitamin D or vitamin A? What should be answer? This was the All India question in 2014, and we must remember it is not only vitamin A, it is both vitamin D excess as well as vitamin A excess, which can cause metastatic calcification. So everybody is knowing about vitamin D, but vitamin A was less known for students. But we must remember vitamin A is also associated with metastatic calcification. How? I will explain you this concept. Retinoic acid, which is present in vitamin A, has a tendency to activate osteoclastic cells. So this retinoic acid will activate osteoclasts in our bone, and we all know that what is osteoclast? These are the modified macrophages of the bone, right? And this modified macrophage of the bone will be using, or they will be causing bone eating, right? And because of the bone eating, they will release calcium into the serum, right? So this will be increased. So that is how vitamin A excess is associated with the metastatic calcification, right? So what happens? Retinoic acid will be activating osteoclastic cells, which will promote bone eating because they are modified macrophage of the bone marrow, and this bone eating will chew the calcium and they will throw into the serum, and that is why hypercalcemia will be there. So this point is very important to understand, that vitamin A and vitamin D both excess can cause metastatic calcification. Metastatic calcification, what is the most common site? This is another important point which examiner asks. What is the most common site? Most common site for metastatic calcification. Most common site for metastatic calcification will be lungs, and in lungs also most common site will be alveoli. So lungs alveoli is the most common site for the metastatic calcification. Apart from this, this can be seen in gastric mucosa also, right? This can be seen in systemic arteries also, systemic arteries. And what I want to tell you here, this metastatic calcification, least commonly, this was the older AIIMS question also and All India question also, least commonly it will be affecting which organ, and answer will be parathyroid. So that was the question in older AIIMS exam. Parathyroid is least commonly affected. So this point we have to keep in mind. Parathyroid is the least commonly affected by metastatic calcium deposition, right? So these are the important thing we have to remember. Calcium deposition, how we are going to identify on the histological examination, right? So this is very, very important. If you remember, when we were discussing about necrosis, that time I told you ki calcium will be chalky white, right? So calcium will be chalky white on gross examination, and on microscopic examination they will be basophilic amorphous material, basophilic amorphous substances, right? So basophilic amorphous substance will be microscopic examination on hematoxylin and eosin stain. There are numerous substances which are basophilic amorphous. So how we are going to confirm? To confirm this basophilic amorphous material as a calcium, we require special stains. And what are those special stains? That was another important All India and AIIMS question. What are these special stains which is required to confirm the presence of calcium? This special stain for calcium are: number one, most important and most commonly used, most common and best, is the von Kossa stain. Von Kossa stain is used for calcium. Just remember this name also, alizarin red is also for calcium. Von Kossa stain was the earlier All India question, right? Von Kossa stain is used for calcium. Alizarin stain can be future MCQ in exam, because this was the one of the option in AIIMS 2013. Remember what I am saying? One of the option, it was not the answer. So my prediction is it could be your future question. Alizarin red is for calcium. And what will be the color of calcium when examiner says Von Kossa is black color, alizarin red, calcium will appear red color. See this diagram? In this image, if you see this image, if you look at this, this is the rheumatic heart disease. So this is how image based question can be asked. It's a cut section of the heart where we can see the valve, and valvular damage you can notice here. There is a deposition of the calcium. These are the chalky white deposition, which is the calcium, right? So these are small chalky white deposition. So these are the calcium deposits. So what kind of calcium deposition? It is dystrophic or metastatic? Can you see? It's the valvular damage, rheumatic heart disease, valvular damage. So it's a tissue is damaged, but calcium level will be normal. So it's a dystrophic calcification. And how we are going to confirm? Okay, this is the calcium. When we take out the section as you can see here, basophilic amorphous deposit. Basophilic amorphous deposit. So that is what I wanted to explain. Basophilic amorphous deposit is the calcium. Basophilic amorphous deposit. Basophilic amorphous deposit is the suggestive of calcium deposition. So we are seeing basophilic amorphous deposit. So these are the calcium. How we can confirm that these are calcium only, they are nothing else? For that we have to use a special stain, Van Kosa stain. So when you are seeing black color, it is Van Kosa stain. Calcium will be black. Van Kosa stain, calcium will be black. Right, calcium will be black. So this is the Van Kosa, and all these black areas are calcium. All these black areas are the calcium. So Van Kosa stain was earlier question, and this is how we will identify. When you are using this one, another calcium stain on the kidney specimen, see this red color. See this red color areas. These are the alizarin red. This is the calcium. All these are the calcium on alizarin red stain. So alizarin red stain, calcium will be red. So this is the calcium which is red in color. So this is how we will identify calcium, right? So now we have seen this calcium deposition also. Last topic of this chapter which I want to discuss is the aging, right? But if you remember, when we started the cellular adaptation and injury chapter, that time we started with cellular responses, and we had mentioned one statement कि progressive sublethal stimuli, progressive accumulation of sublethal, this is very important, progressive accumulation of sublethal, it was not lethal, sublethal. So progressive accumulation of sublethal injurious stimuli, right? So this is the progressive and persistent sublethal stimuli. What will happen in this? Because of this, what will happen? There will be accumulation of the or there will be production of the continuous free radicals, right? Continuously free radicals will be produced. Because of this progressive accumulation of the sublethal stimuli, free radicals will be produced, and these free radicals will be causing damage to the various organelle, cells, tissue, and promote aging. They will promote aging. So now we are going to discuss this topic, last topic, aging. And what is the most widely accepted hypothesis for aging? Free radical injury is the most widely accepted hypothesis for aging. That is why I wanted to describe like this, because of the progressive accumulation of the sublethal injury will activate free radicals, and this will promote aging by doing oxidative damage of the organelle, cells, or our molecular level at DNA and RNAs, right? So this is the most widely accepted hypothesis for aging. This was the question in All India and AIIMS exam. Most widely accepted hypothesis, right? So most widely accepted hypothesis for aging is the free radical damage hypothesis, right? So that is the answer in All India exam. Most widely accepted hypothesis for aging is the free radical damage. This is number one. What are the other hypotheses which is used for the aging explanation, right? So another hypothesis for aging is the increased collagen deposition. So increased collagen deposition is also reason for the increased collagen deposition or increased cross-linking of the collagen, or you can say that increased cross-linking. This wording was used in All India exam 2016 and 17. Increased cross-linking of collagen. Increased cross-linking of collagen is responsible for aging, right? So increased cross-linking of collagen, this was the question in All India exam. Increased cross-linking of collagen will promote more aging. So this point we have to keep in mind. Increased cross-linking, not decreased. That is the very, very important thing. Increased cross-linking of the collagen will promote aging. It's not anti-aging. It will promote aging, right? So what happens in aging, we will discuss later. But before that, I want to tell you one important thing. How we can halt aging? That is another important question which examiner asks. So how we can stop aging? So most effective method. So what I want to tell you, most effective method, this was the another important All India question. What is the most effective method? Most effective method to prolong, most effective method to prolong lifespan. So what is the most effective method to prolong lifespan? So that is the question. Most effective method to prolong lifespan will be calorie restriction, and this is the answer. So most effective method to prolong lifespan will be calorie restriction. So how this calorie restriction can prolong our lifespan? The question comes to our mind, how this calorie restriction will prolong our lifespan, by which mechanism? So calorie restriction will induce one enzyme which is called as sirtuin or family of the protein. So calorie restriction will induce family of the protein which is called as sirtuin. Sirtuin is a protein which will be responsible for anti-aging, right? So when you take appropriate amount of the calorie, neither more nor less, it is not more amount will lead to the obesity and then diabetes and other disorders. Less amount of food will calorie, if you take less calorie, it will cause malnutrition, again it will be hampering your age. But when you are having appropriate, whatever is appropriate is called calorie restriction. This will induce sirtuin. And what is the mechanism of action of sirtuin? This will be another important MCQ in exam. How sirtuin will act? Sirtuin will be acting by decreasing free radical damage, by decreasing free radical injuries, by decreasing apoptosis, by improving or by increasing proper protein folding, by increasing proper protein folding, right? There are two ambiguous things which we have to remember for the mechanism of action of sirtuin. Number one, they will increase the insulin sensitivity. They will increase the insulin sensitivity. And because of increase in insulin sensitivity, this will increase the glucose metabolism also. Increase in glucose metabolism also, right? So increased insulin sensitivity and increased glucose metabolism. Why I said there is an ambiguous statement? Glucose metabolism will be increased, but when we talk about overall metabolism, it will be decreased. Overall metabolism will be decreased by sirtuin, right? That is very important to understand. Free radical injury will be reduced by them, apoptosis reduced, proper folding will be increased, and metabolism is also reduced, overall metabolism. But when we are particular about glucose metabolism, it will be increased. Why it is increased? Because of increased insulin sensitivity. And that is why sirtuin is very, very interesting topic for endocrinologists, because now they feel they can treat the diabetes mellitus. So that is why there are many pharmacological trials where they are trying to prove that sirtuin can cure the diabetes mellitus if it can be induced, because sirtuin will increase the insulin sensitivity, right? Sirtuin will increase the insulin sensitivity and this will increase the glucose metabolism. So this is the impact of sirtuin. So whenever we have a calorie restriction, this is the most effective method to prolong our lifespan, by doing or by inducing sirtuin, and this is the mechanism. Sirtuin can be also induced by a small amount of the red wine. Remember the word which I am saying, a small amount of the red wine, and that could be the future question also. A small amount of red wine can also stimulate sirtuin. Remember, I am writing very specifically a small amount. One should not take, right, in larger amount. Small amount of red wine will induce sirtuin, and that will do the mechanism, following mechanism which I have written here, and this is how they will be preventing aging, right? So in aging, what are the changes you will see? So suppose a person is getting older, so what are the changes you will observe in aging, right? So in aging, you will be finding there will be increased cell damage, right? There will be increased mitochondrial damage, organelle damage, mean to say that mitochondrial damage, organelle damage, right? There will be a decrease in glucose metabolism, right? Molecular level, when you will see, there will be DNA damage, there will be DNA damage. And one important thing which I wanted to mention here is the telomere shortening. So this is important, telomere shortening. Telomere shortening is important topic for exam. So to understand that, what is telomere? Question comes to our mind. Telomere shortening is associated with aging, but what is called telomere? So now we will discuss about telomere in brief, right? What is telomere? What is telomere? Telomere is the short stretches of the DNA. Short DNA stretches, right? Short stretches of the DNA which is present at the end of chromosomes, right? So at the end of chromosomes they will be present, short stretches of DNA at the end of the chromosome. So look, I wanted to explain like this. What is the telomere? Short stretches of the DNA present at the end of the chromosome. So suppose I am showing you, this is the chromosomal arm, centromere, and this is the short arm and long arm. These are the two arms I am showing you, right? And telomeres are these, right? So these are the three blue things which I am writing is T for telomere. So short stretches of the DNA at the end of chromosome is called as telomere. That's all. But what is the significance of this telomere? Why our chromosome require them? Because the telomere will ensure complete replication. So what is the function of telomere? I am writing here. They will ensure complete replication of the chromosome. Complete replication of the chromosome, right? Number one. So number one function, they will ensure complete replication of the chromosome. And number two, this telomere, they will be shortened with each and every cell division. Right? It will be shortened, right? So there will be progressive shortening. Once these telomeres are finished, means they are over, then chromosomal ends will become naked and they will fuse and they will be degraded. So what I mean to say that another important function of the telomere is to prevent fusion and degradation of the chromosome. Fusion and degradation of chromosome. So that is the important thing, right? They will prevent fusion and degradation of the chromosome. So these are the two important things. But what happens? There is a progressive cell division. In our human body, there is a progressive cell division. Because of progressive cell division, there will be telomere shortening. And when telomere will be shortened at one time of the replication, entire telomere will be used up. And because of the entire telomeres has been used up, they will be undergoing fusion and degradation. So this is promoting cell aging. So that is how you will see the cellular aging. So telomere shortening. So now we can see how telomere shortening is associated with cellular aging. So when entire telomere is used up, chromosomes will become naked, they will fuse together and they will be degraded, and this is called cellular aging, right? Telomere shortening is associated with aging. So here I would like to tell you one syndrome. I am very particular about this because in All India exam, this question had been asked 2 or 3 times, and quite challenging type of MCQ which we must remember, and that is the Werner syndrome. One should not confuse this Werner syndrome. What is Werner syndrome? Should not be confused. See what I'm saying? Werner syndrome should not be confused with Werner syndrome. Werner syndrome, right? because we have to focus on two things. See this is the N and this is the M, right? So this is the spelling difference. You can see just one alphabet has been changed and your answer will be changed. So when examiner says Werner syndrome, so remember this point, Werner syndrome is a premature aging, and that was the All India question in 2014, right? What is Werner syndrome? Werner syndrome is a premature aging. What is Werner syndrome? Men-1 syndrome. See, Men-1 syndrome. So both are entirely different things. So be careful and watch the language in your exam. Werner is the premature aging. Werner is the Men-1 endocrine disorder. And premature aging, this was the question repeated in All India exam 2016 and 17. Premature aging is due to defect in which enzyme? Due to defect in which enzyme? And answer was DNA helicase. So this is due to defect in DNA helicase. Because of the DNA helicase defect, this disorder will happen, and this is the answer, right? This is the answer, DNA helicase. So DNA helicase is the reason for Werner syndrome. There was a question in All India exam 2017. What is the function of DNA helicase? So that is the another important question which examiner had asked. What is the function of DNA helicase? So DNA helicase is required for repair, right? It is required for repair and replication. So what is happening? There is a defect. There is a defect in, right? There is a defect in DNA helicase. So as I said, there is a defect in DNA helicase. So because of that, repair and replication will be also defective, right? So this will be the pathogenesis of the Werner syndrome, which is a premature aging. So Werner syndrome is a premature aging because of defect in DNA helicase. Because of defect in DNA helicase, repair and replication will be also defective, and this is called as Werner syndrome, right? Premature aging will happen. So this is all about the chapter 1. Next topic we are going to see, the next chapter we are going to see will be inflammation.